stepping back and looking at population health, community health, and aggregate communities of stakeholders. And so I'm delighted to introduce the first speaker within the session. This is Professor Rafael Perez Escamilla. And he comes to us from the Yale School of Public Health. And I really can't overstate Rafael's influence on improving infant nutrition and addressing food security worldwide. The list of governmental and NGO organizations that he advises, the policies that he's informed, and really a career dedicated toward improving access to healthy living is just spectacular and such a model. So everybody join me in welcoming Professor Rafael Perez Escamilla.
Thank you very much for your kind introduction, and thank you very much for having me here. Good afternoon, everyone, and again, many thanks for your kind invite. From my perspective, the most exciting advance in the 21st century that has a potential to move us beyond the "Breast is best" slogan is the emergence of the field of implementation science. Implementation science involves the systematic application of implementation frameworks, which in turn guide sound implementation research methods and analytical approaches to help understand if and how programs and policies work, and when they don't, what needs to be done to fix them so that they can always work better and better. This is truly groundbreaking because it is starting to allow us to open up the black box that explains how breastfeeding programs work in the complex real world, what facilitates their impacts, and which are the key barriers that need to be overcome. Opening this black box requires understanding and having very good conceptual clarity on what on earth is that we're trying to implement. Is it a policy? Is it a program? Is it a gadget, an innovation? What is it that we're trying to implement? It is also important, secondly, to actually understand through systematic social networking analytical methods applied to identify who are the key stakeholders that need and should be involved in these efforts. We're talking about organizations, staffs, community structures, and so on. Thirdly, implementation research needs to understand the strengths and weaknesses of the enabling environment that is needed for breastfeeding programs to be properly scaled up. And the effort is not going to work if we don't understand the context. The moms are part of a family, the families are part of communities, the communities are very strongly shaped by macro social economic policies as well as cultural roots. And also it is very important at the end of the day, once we have that understanding, to actually follow the implementation science research steps that are needed to actually understand and make the implementation of our policies and programs work and translate it to improve infant and young child outcomes and their nutritional status. An application of these implementation science principles to effective scaling up breastfeeding programs can be found in this chapter that I recently wrote for the wonderful book published by the Family Larson Rosenquist Foundation, Breastfeeding and Breast Milk from Biochemistry to Impact, which I think is very relevant, very well aligned with the objectives of this workshop. And if you read that chapter, pay a lot of attention to the section on complex adaptive systems frameworks, which are a gift that has been given to us by our colleagues that do healthcare systems research. At the end of the day, we truly want to understand how to properly scale up with quality the baby-friendly hospital initiative. It is very much a healthcare systems research question. If we want to better understand how to integrate health facility with community-based breastfeeding protection, promotion, and support efforts. We have to understand from the point of view of the healthcare systems, the social protection systems, the labor systems, how to do so. The complex adaptive systems frameworks have identified a number of key principles, including the positive or negative feedback loops, that their balance at the end of the day determines whether a program can be successfully scaled up or not in a country. At the end of the day, we are doing all this work because we are trying to understand the principle of emergent behavior. It is a third law of thermodynamics. How on earth can order come out of all the chaotic world under which all these systems operate and these complex organizations behave? So the CAS is indeed a conceptual framework behind the aided model, which in turn is the one that guided the development of the breastfeeding year model that I have presented so many times, and I don't need to do that again during this meeting, but you can read all about it. A second very, very important implementation research tool that we have is the program impact pathways analysis or methodology, which falls within the family of what we used to call process evaluation and what we're calling more and more quality improvement evaluations. The PIP, or program impact pathways, was formally established within the field of nutrition by Jean-Pierre Habib and his colleagues at Cornell University. And what they did was actually to bring causal thinking for understanding what programs do, how they work, and if they're actually meeting the expectations for which they were designed to operate. In this report that I also recommend all you to read, they include a very interesting analysis of what was a very visible child nutrition program in Peru, where essentially they were training community volunteers or community health workers who in turn provided group-based education to women with young children so that they could improve their own nutrition as well as nutrition of their infants and young children. And using a very static results framework approach, which was the norm several years ago by USAID, all the programs had to be mapped according to the framework. You can see that they clearly identified the need for the actual documentation that yes, the knowledge and practices and attitudes are improving among the women who are participating in these education groups or counseling groups, but that at the end of the day, there are all these structural factors that need to be addressed, including access to the healthcare system and assuming that they will have access to food when they go back to home, access to healthy foods, immunizations, and also that there will be improved sanitation in the communities and strong engagement with community-based organizations and other societal actors. This is very nice and very well conceptualized, but at the end of the day, it really doesn't help anyone to understand what this program is supposed to do, how it is supposed to operate. So what they did, they went to Peru and actually conducted the interviews with key stakeholders from the national all the way to the local level. And what appears to be a very simple program, you train community volunteers who then educate moms, and then life is very happy ever after. Essentially, it's a very, very complex program. It's as complex as an electronic circuit inside a computer. And what it does is to actually take you step by step in terms of which activity needs to precede which one for ending up with a successful outcome. And it really allows the program managers to reflect if this is really what the program is powered to do, has the resources to do, or if they should actually rethink what is the whole goal of the programs. It is a technique that allows you to identify critical quality control points. It's very similar to HACCP, what the food industry uses to monitor the food production processes. And what is very interesting about one of the key findings in defense of fathers, which I wanted to make a comment about, and this is a perfect moment to do that, is that, of course, you know, they said, well, everything starts with moms actually attending the support groups. There has to be demand for the program. Well, what they discovered is that this program was kind of a ghost because very, very few mothers were participating. And when they started talking with the frontline personnel, why this is happening? Well, because their husbands are not welcome. This is not a program that had a strategy in place to include the partners, and this is preventing the mothers from participating. And to make a very long story short, in many ways, fathers have not been participating because the UNICEF caregiving framework for over 2 decades excluded them explicitly from these types of activities in a very stereotypical way and in a very, very negative way. And now UNICEF has moved 180 degrees, and many of you were mentioning the enormous efforts that are happening in many countries to actually include the partners, the fathers, and other key influences in these programs. Otherwise, you know, they're just not going to work. We have applied the program impact pathways to actually understand how our becoming breastfeeding friendly strategy works. We have our colleagues from Wales here, from the UK, who are very engaged in this process. Germany is doing it, and we have 6 additional countries that have completed this process. And we have recently published a paper showing how the PIP approach works within the context of the BBF initiative. And this is really allowing us to design very specific, very intentional policy research approaches to answer very key questions to help us open the black box of what makes policy recommendations become a reality or not in the real world. So I will finish my presentation by giving you an example of how we use all these principles that I just mentioned to conduct a 3-year evaluation of the impact of UNICEF's Community Infant and Young Child Feeding Counseling Package in infant and young child feeding practices in Kaduna, Nigeria. And this is work that I co-led together with my colleague Sasha Lamstein from Spring. So the UNICEF's counseling package is a very remarkable evidence-informed package that covers many aspects related to breastfeeding, complementary feeding, really any feeding issues during the first 5 years of life. It addresses sick children, it also addresses maternal nutrition, it gets into preventing family violence, it gets into family planning issues and so on. And it is a very nice initiative because I spent a lot of time thinking about how to develop the guides on how this should be implemented, how this should be adapted in different contexts. So in 2013, the Federal Ministry of Nigeria actually finalized a number of years of work adapting and pre-testing these materials in the country and decided that they really wanted to go for global dissemination in one of the largest countries in Africa, if not the world. The package is currently being applied in over 60 countries. Very few, the ones in blue are the only ones that are applying, it's like the WHO code. Very few are really applying the package the way it should be applied. But the fact of the matter is that it's being widely used and no one before this study knew if it was working or not. So the study location was the state of Kaduna, and we worked with an intervention local government area of about 200,000 people, Kajuru and the comparison group, Kauru. I didn't come up with the names to confuse you, so I will just say intervention and comparison group, but that's where the study was done. And of course, we population and cost that needed to be measured, and how important it was at different time points to assess knowledge acquisition, not only by the mothers, but also by the healthcare professionals who were responsible for training the community volunteers. If we don't measure if there is knowledge and attitude change there, the program is somehow should not be expected that is going to work by magic. We used mixed methods in design to very specifically answer several of the big guided questions. And to make a very long story short, we had a lot of success with significantly improving more in knowledge, attitudes, and practices in relationship to breastfeeding initiation within 1 hour after birth in the intervention versus the reference area, and also improvement in exclusive breastfeeding that was twice as high in the intervention compared to the reference group. We attribute the success of the program to several factors. The first one is that we had adequate time and resources for planning and guiding our work through sound implementation science frameworks since the very beginning, and to understand when we were ready to launch. And also the implementation fidelity was very, very, very strong. Why? Because the PIP allowed us to very closely monitor and take remedial action on time to make sure that the program remained on target. So in conclusion, the counseling package was successfully implemented in Kajuru. The counseling package had a positive impact on key breastfeeding outcomes. PIP proved to be a very, very powerful method for quality improvement, quality assessment, evaluation in the context of a complex adaptive systems framework. And in terms of the other question that I was asked to address, which was the biggest challenge, well, this is not something that you can just do alone at home. This really requires major multi-institutional coordination and participatory governance throughout, from community to NGA to state to the national level. And we grounded this on CBTR principles. It was not easy, but we learned a lot along the way. And I think this is going to help other countries that want to replicate or to disseminate this package into their communities in an evidence-informed way to do so. They are much better now than, much better at a much better point now than what we were 50 years ago. Thank you very much.
All right, our next speaker is Professor Nathan Nickel here at the Department of Community Health Sciences at the University of Manitoba and one of our co-hosts. And Nathan is really a rising star in the area of evaluating and implementing effective health interventions at the community level. And he does this with a deep commitment to health equity and justice and the intersections that need to be incorporated in order to actually reach effective implementation. So please join me in welcoming Professor Nathan Nickel.
Just want to thank everyone for coming. I'm not going to thank for being invited because I invited myself. But I will be focusing a little bit more on a broader picture than some of the conversations that we've had so far, partly because I feel like breastfeeding and infant feeding and lactation need to be considered within this broader context. And I begin by just iterating something that I share with my students. So I teach Epi in the College of Medicine here at the U of M. And the first thing is that health doesn't occur just at random. It's not that some of us are just randomly struck by lightning and suddenly have good health. And some of us randomly are struck by lightning and have bad health, although I did injure my back this weekend in a way that I felt was completely random. But instead, there are systems and processes at play that end up either promoting some people to have optimal health or systems and processes in place that serve to undermine someone's health. And so that's the one of the first fundamental assumptions that we have is that health isn't random. And the second is that we can use a systematic process in order to identify why some people are healthy and some people are not healthy. And I would broaden this even a little bit more to the question of we can use systematic processes to identify why is it that some mothers are able to achieve their breastfeeding intentions, and why is it that some mothers are not able to achieve their breastfeeding intentions. So my main research questions was one of the things that we were asked to focus in on, and I am fundamentally interested in breastfeeding inequities. So whenever we observe a difference in breastfeeding initiation, in breastfeeding duration, that follows a socioeconomic gradient, the question that I ask myself is, well, is that difference fair, or are there some systematic processes at play that are resulting in an unfair difference in breastfeeding outcomes? And whenever we look in the data, or I shouldn't say whenever, but often when we look in the data, we find that breastfeeding outcomes follow a socioeconomic gradient, where families that are more privileged are often more able to achieve their own breastfeeding intentions. And we see this routinely across many, many different countries. And over time, and we see that breastfeeding inequalities in some countries have been increasing over time, in other countries has been decreasing over time. Or in Manitoba, I did a study looking at breastfeeding inequalities over 20 years and found that largely the gap between the most disadvantaged and the most advantaged in our population has remained relatively constant. And hearing the conversations from earlier this morning, when a mom isn't able to achieve her own breastfeeding intentions, we heard the stories this morning about there's a lot of anger about that, there's a lot of frustration, there's a lot of negative emotions. And so the next story that idea I leave my students with is that epidemiology is fundamentally the story of human lives, but with all of the tears removed. We talk about infant mortality indicators. We talk about indicators where a mom is or is not able to achieve her breastfeeding initiation. We boil those down to numbers, and it's really easy for us to forget that each of those numbers reflects a real family's experience, and we can't lose sight of that in the work that we do. So I have a lot of focus on equity and equality, not just in breastfeeding, but in my broader area of research. And when I first moved into the equity stream, perhaps some of you have seen this slide before around what is equity and what is equality. And so you see short, or as I like to say, because I am one vertically challenged individual who is not able to participate and observe the baseball game. And even though they all have the same supports, some folks are able to observe the game and others are not. And equity is about making sure that everyone can see over the fence. Now, I don't like this picture all that much. I don't like it for a few reasons. One of them is I don't like baseball. If I were to want to have a sport, I might choose something like UCLA basketball, which has a lot of NCAA championships, just putting the plug out there. But there's another issue that I dislike about this picture is that it ignores why is it that some are not able to see over the fence while others can. And it places some of the onus on, well, that kid's just short, and so that's why they need extra help. So I've created another image, and I'm not a graphic artist, so I need to hire someone to do this true justice, where everyone's at the ocean and they want to see the beautiful sunset and look out over the Pacific Ocean. And each of those people are exactly the same height. They just happen to be standing at different elevations. Systems have resulted in one person being elevated up, and systems and structures have resulted in another person being at a lower elevation, but they can all see the ocean, and we're really happy. Unfortunately, a fence is built, and the fence prevents some folks from being able to see the ocean, but other folks are still able to see the ocean in spite of the fact that the fence is there. Also draw your attention that the fence is not flat. Notice that the highest part of the fence corresponds with the person who is at the lowest elevation. And so equity is about trying to bring everyone else up so that they can still enjoy the view of the ocean. But one other argument might be that perhaps we should decolonize or deconstruct some of the barriers that exist in our system so that instead everyone can enjoy the ocean equally. There's also problems with this. My favorite analogy is by Dr. Kamara Jones with a cliff analogy for public health. I'm not going to go into it, but look it up. It's great because it talks about the 3 dimensions of health disparities and structural and social determinants of health. So returning to breastfeeding inequities, one of the questions that I'm interested in asking are what are the social, structural, and systemic barriers that are creating breastfeeding inequities? What are the systems that we have in place that are making it so that some families are able to achieve their own breastfeeding intentions and other families are not? And do any of these barriers serve as effect modifiers? Do they change the relationship that might exist between breastfeeding and health? And then are there strategies that we can put into place to remove some of those barriers so that all families can achieve their breastfeeding intentions? So some of the work that I've done and some work that others have done has shown that what happens in the hospital is really critical to success for breastfeeding, not just breastfeeding initiation, not just breastfeeding exclusivity at hospital discharge, but also at breastfeeding duration out to 3, 6, 12 months of age. But some of the other work that I've done, that I've been a part of, has also shown that even though we have good, strong evidence as to what practices remove barriers to achieving your own breastfeeding intentions, not all women have those barriers removed from them. So most people know me as a quantitative researcher, and that's what I spend most of my time doing. I have done qualitative research. I interviewed just over 100 healthcare providers in North Carolina, so nurses, physicians, to hear about stories around providing breastfeeding support in the hospital setting across both rural and urban North Carolina. And the comments that I heard back during my key informant interviews were along the lines of this. If I walk into a room and I see a black woman, I'm not going to talk to her about breastfeeding because she's not going to be successful. Or we can never improve our breastfeeding rates because we have a large Hispanic population. Or Hispanic moms are going to mix feed no matter what we do, so why should I even try? And being from Los Angeles and moving to North Carolina, I thought maybe that was unique to North Carolina. I did another study with the New York Department of Health in New York City, where again we interviewed about 75 healthcare providers in New York City, and we heard the exact same stories. Races might have changed, Hispanics were still common, blacks were still common, but we heard about other populations who just won't breastfeed, so I'm not going to bother providing that care. And even here in Manitoba, we hear the same stories of why should I engage in this conversation around breastfeeding decisions when I know that these families aren't going to partake, are not going to choose to breastfeed. So we see it also in the quantitative data where families from social disadvantage tend not to experience or receive care practices that have been shown to support breastfeeding initiation, exclusivity, and duration. So returning back to a comment that Dr. McGavick made earlier, what are the systemic and structural racist practices that exist in our healthcare system that might serve to exacerbate inequities in breastfeeding outcomes? We also know that what happens in communities has a big impact on breastfeeding success. So we've heard about peer support programs. Some other work that I've done here in Manitoba, we have an unconditional cash transfer program that exists. It's called the Healthy Baby Prenatal Benefit. If you earn under a certain amount of money, you'll receive up to $81 a month. We found that check was associated with increased breastfeeding initiation, and we found that check was associated with decreased breastfeeding inequities amongst First Nations families. We found that check was associated with decreased breastfeeding inequities amongst Métis populations. What's interesting though about that, $81 a month, that program has started in the early 2000s. $81 has not changed over the past almost 20 years. We did a supplemental analysis over the fall because I was curious. $81 a month buys a lot less today than it did in 2001 when the program was initiated. And we found that the impact of that $81 a month has been declining steadily over the past 19 years, and so now is no longer statistically significant, which again supports an idea of a dose-response relationship between providing an unconditional cash transfer during the prenatal period, early life, and improved breastfeeding initiation rates. So what am I excited about was one of the other questions. As we go through our life, we generate a lot of records and a lot of data. If you went to university, I'm sure all of us have our transcripts. Some of us might even know our GPAs that we graduated from university. We're all high achievers. When we go to the doctor's office, we may not know exactly what happened to us, but a record is generated about the diagnoses and the procedures that came out of that doctor's visit. Whenever we get pulled over by a cop or if we're involved in a crime, a record is generated that documents what happened in that interaction. And so what I'm excited about is figuring out a way, can we pool all this information to develop a really holistic and rich picture about what's happening in people's lives. And so with families here in Manitoba, every time someone goes to the contact with the healthcare system, whenever they go to school and they get education records, they come into contact with justice, or they receive any one of our many, many social support programs, records are generated and copies of those records are sent over to the Manitoba Centre for Health Policy, which is where I spend most of my time. And what we do is we bring those data together at the individual and record level in order to construct a really holistic picture about what's happening in the life of a person and as it relates to health. So we have 1.2 million people in the province of Manitoba, and everyone who's registered with our universal health care, so 99.99% of the population, is captured in this data system. So what type of data do we have? We have just under 100 databases, and they span things from hospital records, pharmaceutical data that are generated during the hospital stay, nursing home records, home care, vaccination visits, vital stats, pharmaceutical drugs that are dispensed in community, emergency department visits, on and on. Over in the blue, you see that we also have everyone's education records. So if you went to high school in Manitoba, after 1995, we know how you did in school. Family services, income assistance if you were ever part of social housing, received any healthy baby benefits, and all the contacts with the justice system. It's a lot of information, and we can put it together to follow a person through life to say what's happening during the prenatal period. How old was a woman when she became pregnant? What was her marital status? How many prenatal visits did she have? Did she receive the prenatal benefit? And then we can link that in with some survey data, find out about a little bit more about the community. We can pull in information about the baby's birth, information about whether they're receiving social supports or in social housing, follow the kid up into early childhood and into school, starting to get their school records, and then follow them on into high school and beyond. What's nice about this is think about school data. Many times we only know what happens to those kids who take their tests in school, what happens to the data for those children who drop out of school. Because we have everyone, we're able to know who is in school, who dropped out, and account for that in our analyses and looking at, say, education outcomes that might be associated with breastfeeding. So we spent a lot of work when I first moved up here creating a resource in order to do child health research that would be able to link not only follow a kid as they go through all these different systems, but connect the child with their parents to start to do intergenerational research. Our data go back to 1971, so we're now able to generate and look at grandmothers, mothers, and then their kids' outcomes as they relate to health and many social outcomes, starting to develop a really nice intergenerational picture of health. What was missing when I moved up here was we knew breastfeeding initiation data, but we had no idea what happened after hospital discharge. And so several of us here in the room have been working on developing an infant feeding database that will capture infant feeding information throughout the first year of life that can then be connected back in with that repository to understand not just breastfeeding behaviors, but how do breastfeeding behaviors situate within the broader social context that a family is living in. So the data are collected during routine well and child visits. We collect information on infant feeding, but as well personal identifiers that then lets us link that infant feeding information in with the population repository that we have at the Manitoba Center. The data are collected on a form like this, and this is I wanted to touch on, I wasn't going to touch on this, but a comment earlier about how a mom communicates her breastfeeding behaviors to a healthcare provider and whether or not she is completely transparent about feeding decisions. As part of this project, we varied how this form is filled out. So in some locations, the form is filled out by the mom in the waiting room, and in other locations, the form is filled out by the public health nurse, and he or she asks the mom, how are you feeding the infant? What's interesting is the location where the public health nurses are filling out the form, they've been doing their own data collection. And in some locations where the mom is filling it out herself, they're also doing their own data collection. And what we're finding is when a mom fills out the information herself, we have much lower breastfeeding rates when compared with the data that the nurses are collecting. So at first there was this disbelief. We have an 80% breastfeeding rate, and I'm saying, well, no, my data actually say you have a 50% breastfeeding rate at 4 weeks. And so talking about what might be happening during that dialogue about how a public health nurse is asking about it versus how the mom is filling in the information. So I am about going over time. So the one thing that I wanted to just highlight is by bringing in this information, I'm excited about being able to look at breastfeeding within the broader social context. I'm more of a pop health person. As was mentioned earlier, and I think Megan is also going to talk about, Megan, Lauren, and I are going to be co-leading the Manitoba Interdisciplinary Lactation Center. So along with having breastfeeding behavior information from the infant feeding database, we're going to be collecting milk samples as well that will be linked in with not only the infant feeding data that I've collected, but also linking in with the repository so that we can begin to examine questions like what's happening when a mom takes a pharmaceutical drug, because we have the data on that from pharmacies, as it relates to human milk composition, and how does that then impact a child's health and development during the first several years of life. So we're starting to form this interdisciplinary team to take breastfeeding from not just a breastfeeding study, not just a human milk study, but actually thinking about it from a cell to population level and explore things across the spectrum. Upcoming breakthroughs, so I can't ignore my interest in equity. And so one of the questions that I have is how do the social structural determinants impact the biology of human milk and lactation? So there's evidence and discussion around things like allostatic load as it relates to reproductive health. How is that now, how might that impact breastfeeding and lactation? And do we see that that might be a moderate effect modifier on the potential relationship that might exist between breastfeeding and child health outcomes? And then secondly, can we identify strategies to remove those barriers? And finally, some of the challenges that I see is that being able to link biological data to holistic data on structural determinants, we need to be very cautious about the intersection between just culture and data. What do I mean by that? We've talked a lot about collecting biological samples, and I'm really excited about that. As we partner with some of our some populations that have been systematically marginalized, it's important to remember that taking biological samples is not seen as the best cultural practice in all communities, and in fact violates cultural norms in some communities that are the most marginalized. And so we need to think very thoughtfully and carefully about how do we engage in this type of research when it might actually be taboo in some communities. The other point that I'll just leave you with as I end is, as we're dealing with lactation and breastfeeding research, oftentimes the systematically marginalized get left out of our studies. So if we think about human milk studies, and we think about the sociodemographic distribution of the participants in our human milk studies, who do they tend to reflect? Often they might, many studies tend to reflect socially advantaged populations. Who gets missed in that? We end up seeing that the marginalized populations, their voices become invisible, and we're not able to actually hear their stories. So another situation, we see that as well in cohort studies. It's very easy to keep and retain upper middle class, well-educated families in long-term cohort studies, but that ends up systematically silencing some of the most marginalized populations that, from a health equity perspective, we want to make sure we are able to privilege. And so with that, I will end my time. Sorry for going over.
So the last speaker in our session today is Professor Kathleen Rasmussen, who everybody is quite familiar with, but I'm going to make her listen to me talk about her. Kathy has an incredible research toolkit where she has worked doing intervention studies, epidemiological studies, different kinds of observational studies in the global south, in high-income countries. She's worked with animal model systems, and she has continuously expanded and pivoted her research program to specifically address the needs within community and clinical settings. So what you have with all of this is a powerhouse research program that is visionary in filling key gaps in knowledge that families really need. And so thank you for your response to the research program, and please everyone join me in welcoming Kathy to the podium.
Yeah, thank you very much. It was interesting just to listen to the last couple of speakers and say, where do I fit in this population stuff? Because I didn't bring you any of that. Okay, and I have the most imaginative title here. So you asked a couple of questions, and I'm going to answer try to answer three of the five of them. And the first one is current research questions. And so I phrase this to think about the two graduate students that I have on board. And all the population research is in the middle between these two, and it's all being done with collaborators and not with graduate students, or at least not graduate students at Cornell. And you gave me 15 minutes, and I teach, and I take that seriously. And teaching for me is 50 minutes, 75 minutes, or 90 minutes, and you don't want any of those, so I'm keeping it simple. So one of my graduate students has taken me in a direction I never expected to go, and without help from Shelley McGuire and a guy named Anthony Hay on the Cornell campus, we would not be doing this. So the first question is, how do pumping and storage of pumped milk affect the bacterial composition of human milk? And the student involved is Sarah Reyes. And some of you might have heard her at the lactation conference in Japan. This is a randomized clinical trial where women were assigned randomly to either use their own pumping setup or a sterile pumping setup to take a milk sample. And then whatever was chosen first, the opposite one was used the second time. These have provided analysis of the microbiome sample both at the time of the first collection, which is a manuscript that is fairly well developed, and then longitudinally over time for 30 days with samples collected at the time that represent current recommendations. So we will be able to say how the microbiome changes across these various storage procedures. This is very practical stuff. She calls it pumping. The milk study refers to pumping under real life conditions. So that makes me happy. It's a kind of an intervention randomized trial. The opposite side is territory I also very much depend on collaborators for, because qualitative research is not where I started out. So the other thing we're doing is asking the question, how important a public health issue is sharing of expressed human milk? The student here is Jennifer Paraguay. And again, those of you who went to Japan had a chance to hear her. She won the student prize. This is a two-phase idea. It's a qualitative study of women's motivations for and perceptions of risk related to milk sharing. And it's going to be followed by making a quantitative estimate of the proportion of women who share their milk or receive shared milk. Milk sharing is still a pretty closeted behavior. We really have no reasonable national effort estimate of how common it is. And so she's going to use a technique called RDS sampling, which is used for things like HIV networks to do a network-based estimate of how common this behavior is. And she will get both women who receive shared milk and women who share their milk as this. We don't know squat about this. So even just, this is so basic, we need just a prevalence estimate. So when you ask me what's exciting about my current research, I have to say seniority has its disbenefits. And one of them is you recognize how long it takes between that exciting day when you've got that grant proposal all worked out and the time you actually see the results, at least in the dissertation. Years. It takes years. That dampens your excitement on any one project. You have to sort of have a bunch of different projects to keep your excitement going. So my answer to that is where I find exciting is combining the past results that we have on any one line of research with those of our current projects. And for these two in particular, it will improve our ability to help women understand more about the various aspects of what it means to choose to pump. And that's all about the time, it's all about the cleanliness, it's all about the effort, and it's all about the responsibilities that also come with having a supply of expressed milk. And the women would like you to think it's liquid gold, and it is indeed liquid gold in terms of the effort that they have gone to create this frozen stash, I think is what? Freezer stash, yes. But it also, when shared or sold, is not necessarily such liquid gold. It could be donated and be liquid gold if it were pasteurized and could be shared with more people, but that's not necessarily the case. So we have the opportunity to understand this freezer stash in a lot of different ways that might change what we did with it and could create much more benefit than it's creating now. And just think about what you've been saying today. There are a lot of ways we could use that milk. So I'm going to spend the rest of my time talking about barriers, challenges, and solutions. I think the barriers fall in a couple of categories, and one of them is cultural. And I am speaking here particularly from the U.S. context. I can't speak for Canada here, but in the U.S. context, we are very much more interested in babies than mothers. Our national infant mortality statistics are an embarrassment. Our maternal mortality statistics are worse on an international level. They are just disgraceful, and we don't seem to be doing a whole lot about it. Unfortunately, our healthcare system is set up to address the mothers and the babies separately. They each have their own doctors. The mother has the gynecologist, obstetrician, the baby has the pediatrician. And our previous research has shown, this is particularly with respect to women who are obese and want to breastfeed, that everybody thinks it's somebody else's problem. And that somebody else it winds up on is the family medicine physician, who are rare in the U.S. They might be the GP that's everywhere in other countries, but for us it's the family medicine doc, and that doctor is rare. Or it's a lactation consultant, and they don't work 24 hours a day on hospital schedules. Lactating women are quite literally seen by no one, because by the time the woman leaves the hospital, she's now back in the care of her gynecologist, and her gynecologist will not see her for another 6 weeks. And by then, everything is done and through with breastfeeding. She's either successful or she's not, and she's had no help from her gynecologist. And the child's pediatrician in the U.S. context will not talk to her about her breastfeeding problems. And if she has a problem with the baby, formula is often the answer, unless she has a very enlightened practice. And we do have such enlightened practices in Ithaca with multiple lactation consultants who can do such things. And we also have practices at the other end of the spectrum, even in this one town. I also want to talk about barriers and challenges in the research area, and I want to start with USDA. For the last more than 40 years, the USDA has failed to invest in studying the nutritional components of human milk. Shelley and I, and maybe some others, went to a meeting last year, well, it was November of 2017, held by NIH in Washington, and found out that USDA has just discovered it has no new value for the nutritional composition of human milk. Shelley's chuckling in the back because it's true, they don't. We are in no position to revise the dietary recommendations for babies because we have no new data. And all these wonderful new things we found out exist in human milk, zip, count it, zip, zero, zilch, nationally useful data. And no study, as I say, of these new things that really are quite important for infants have gotten into this database, although the data are, to some greater or lesser extent, might be available and could be used in some form or another, but there's no attempt to do that yet. There is some small increment in the embarrassment at USDA about this, but not enough increment in embarrassment to collect new samples yet. We can't leave NIH out of this because they have really also been a problem, but of a different sort. So for decades, they have been remarkably uninterested in research on lactation, unless, and this is not a small unless, it involves a high-tech investment. Oh, like oligosaccharides. There is technology there. Or an experiment. What was that? Yes. But for an experiment to happen, we have to be ready to do the experiment. And there are many problems in public health for which we do not have adequate information yet to actually conduct an experiment. We need another observational study of some sort or another to help us properly identify the problem so we can come in with the experiment that we need. So my best example of that is that despite increasing proportion of women who are too heavy at conception, we lack evidence-based guidance to help them address the breastfeeding problems that they are more likely to experience. We already have evidence that they are more likely to experience these problems. We know what they are. We know who's not helping them. But that doesn't mean we have the right intervention to address the problem yet. And that takes a kind of research that isn't yet available. So when you take this to study section and they say you have to do an intervention, we won't fund another observational study, you are stuck. This reflects both NIH's high-tech bias and, I have to say, sufficient reviewers with expertise in lactation. So if you are submitting a grant application to NIH and it has anything to do with lactation or breastfeeding, be sure to write a cover letter and name names about who you want on that panel. And you have to really be hopeful that they'll be in the room and not just on the phone. The consequence is that in addition to the composition of human milk, most aspects of lactation remain or understudied, at least in the US. I also want to tell you that barriers exist at most levels of the study of lactation, but so do opportunities to solve these problems. And of course, not all of these problems involve research, but they may require quality evidence to create useful policy solutions. And for this, I can't help but being the professor of public health nutrition that I am, or at least a course in public health nutrition, which I'm teaching at the moment. Not as I speak, because somebody else is doing that for me today and tomorrow. But many of you who have a public health background are familiar with this picture, which is the socio-ecological model. And I wish I had a pointer that works, but you'll just have to look at the middle, which considers the individual at the middle and their sort of biological characteristics, and it works its way out to their individual behaviors, their social and family environment, their living and working environment, and the broad social, economic, cultural, and health. Oh, she gave me something, but I can only use it on one side, guys, so you're gonna, if I can find it. No, ooh, that knocks over here. I'm gonna give this back to you because I can't reach right now. Whoa, very well. So you can see that this circle moves a pie is viewed as a slice of this. It looks like a triangle, and the triangle looks like this. So again, for those of you who are public health experts, you will see what I'm going to finish with is the public health pyramid as applied to breastfeeding. So at the top of that pyramid, I actually don't think is the woman. I think what's at the top of the pyramid is milk. The milk that she produces, the milk that her body determines what she can produce, and the milk that then serves the recipient infant, whether it's hers or someone else. And here you can think about, so here on the left side is what the concept is, and on the right side are some examples of it. So here we might be thinking about how maternal health is related to the milk microbiome. We don't know anything about that yet. How the microbiome is related to other components of milk. We certainly think the microbiome is related to individual health, but we haven't thought about how the milk microbiome is related to individual health of the baby. That's yet to come. And of course that means in the moment and over some period of time. The second level of this would probably be the characteristics of the lactating woman, and we know lots of things about her that affect her ability to produce milk, her health status, the mode of delivery, her age, her history of prior lactation. I could go on. Some of these are immutable and are established at the time she conceived this particular fetus, but others are potentially changeable. We've given a lot of study to this, but we haven't translated much of this information into interventions that would help this woman to be more successful in breastfeeding. And of course that comes back to my obesity example. The next level would be the social and behavioral deterrents of lactation behavior. And these include social support for the woman's chosen method of breastfeeding, her knowledge of the various kinds of feeding methods. We've heard lots about this today. We have a lot of room for improvement here, but we also need different kinds of studies than the ones we've done previously. We need more of them, and we need to be thinking holistically about women. They're all not equally interested in breastfeeding. They may or may not have high intention, but even women without high intention can breastfeed really quite successfully. Maybe not all the way to 5 years, that might be pretty unusual, but nonetheless, it's possible. We need to think about the possibility and not tell women, not make the assumption that for women it's no. For our heaviest women, we need to recognize that doctors are just seeing how heavy their body is, and the medical problems. But this could still be a woman who really wants to breastfeed and might be able to do it if she had adequate support. We need to find a way to reach her. Then you could think of the living and working conditions of the lactating woman, and this refers to her workplace environment, her maternity leave, her access to a pump, and now we heard there are even more high-tech pumps, her time to breastfeed, her time to clean her breast pump. All of these things matter to her ability to make breastfeeding work in her life. And I'll stop at the end with government and community level policies for programs related to lactation. I hate to tell you, my home state, New York, has had to pass a right to breastfeed law, so women would not be hassled for breastfeeding sitting on a park bench. Oh, bad, bad. Policies that address the needs of lactating women are various sorts are important. Now, if you think about this as the public health pyramid, what you recognize is the layer of greatest leverage is not at the top, where we spend most of our research money, because most of our research comes from NIH. The area of greatest leverage is actually the bottom layer, because the changes you make here affect the whole population if you're successful. But that does not mean we should take this bottom layer not seriously. This bottom layer is very, very important. And I want you to think for a moment about a guy named Larry Brummerstrom, who unfortunately is not able to be here, I gather, who was for years the guy in the US government who managed breastfeeding. He systematically worked through every single lever he could pull as the guy at the Centers for Disease Control, everything he could pull that would change breastfeeding, whether it was blaming and shaming through the MPINK report and getting people to count their exclusive breastfeeders and go baby friendly, whether it was data by making the states collect their own data and giving the states a report card that they could then use to assess their own progress. And of course, we value what we count, and we count what we value, and he got us to count breastfeeding women. Now, he's now taken his act to the World Health Organization, and we will probably see some of the same things there. But I want you to think that some of the things that we in this room could think about doing happen at this bottom layer as well, and thinking about what we could do with our own governments, what kind of data they might need, or that we could collect, that can convince them to collect, is really quite important. And with that, I will stop.
I'll pinpoint, I'll ask Nathan to comment. So I work in the area of childhood obesity, and we have one more layer on the bottom there, and that's colonization and historical structural racism. If the government's involved, then you got to get through that. So Nathan, based on your talk and then combining it with this, that's a bigger lever, right? Potentially reduce inequities.
Yeah.
How do we shift that lever?
Yeah, I think that's actually one of the, so the question just for like, government policies are embedded within a context of historical trauma, colonialism, and institutionalized racism. Personally, I think that that's actually one of the interesting areas of research that needs to occur. We haven't been successful at decolonizing or dismantling structural racism in governments, at least in colonial governments, to my knowledge yet. We don't have a proven model yet that works for that.
And no one funds that either.
Yeah.
You're not going to get a grant for that.
So the comment I want to make about that is that in my experience in Connecticut, the vast majority of stereotyping is not intentional. And I think that people are reflecting their upbringing, and many of them have actually very good intentions. They don't even understand that they're part of this system. So our approach in our group and our community partners was to develop a very, very strong diversity inclusiveness training that has been implemented throughout the Department of Public Health in Connecticut, medical schools in Connecticut, and actually is along the lines of Cami's presentation. It's about giving people an opportunity to reflect on what they think about other people, and why they think that way, and what things they can help change in their institutions to change that. So I think that there isn't a magic bullet, but that it is important to acknowledge that a lot of people are trying to do their best, and they just don't understand that they're part of a very, very difficult system for underrepresented minorities.
I have a question for Kathy and maybe Rafael. What you say about NICHD's lack of interest in funding lactation research, and then the lack of expertise on study sections. Maybe this is just rehashing what's been said a million times before, but do you think there's anything that proactively a group could do about it, about trying to ask for a special emphasis panel that would focus on this, or to bring this issue to NICHD in today's environment about why this should be a priority?
Well, I'm speaking about NIH in general because funding for research that's conducted in this room comes from a lot of institutes besides NICHD. What was very important when what's now the International Society for Research on Human Milk and Lactation began was a champion, Thorsten Felsted, who was at NICHD, and unfortunately, or fortunately for NIEHS, he moved to North Carolina many years ago. We don't have such a champion now. If you have a big enough project or enough projects simultaneously, you can go for a special emphasis panel. But I think what's within your power personally is that cover letter that allows you to ask for reviewers with the skills that you think are necessary.
since 2010, we started pushing and pushing and pushing the government for the need to include kids between 0 and 2 years of age. Everybody told us it was beyond our mandate, it was not our business. To make a very long story short, Congress created and released the funds for the B24 committees to be formed, and for this group to be included for the first time in the dietary guidelines for Americans in 2020. And there is now an initiative from the NIH with funding that just came out to the RFPs to fund pregnancy and B24 projects. So,
but not now. No breastfeeding, no lactation.
Well, B24 includes breastfeeding. I mean, it depends what people apply to get funded. But before, there wasn't even this emphasis in dietary guidance, and now there is. So I think it is very important, in my experience, that we also engage, and we have access to those high-level panels that have major policy implications. That whose work has major policy implications to advocate for this, and it can end up happening.
Okay. Thank you.
Maybe in addition to getting the lactation experts on the NIH panels for as reviewers, what I would also recommend is bringing the lactation science to other societies that then get aware, oh, there is such thing as an important aspect to human biology, disease, whatever it is, and that has to do with lactation. So the next time they see a grant when you spoke at their conference before, or you are part of their society, they are aware that there is actually value to human milk research, breastfeeding research. So I think staying only in that silo with nutritional and other things is good, certainly has its value. But I think bringing human milk and lactational research outside of that society is also very important, because otherwise it's just going to be a group of 300 or 500 people, and how many of us can sit on NIH panels all the time? I think we really need to bring this outside of the field as well.
Good point.
Okay, I think that's a good comment to move into coffee break.